Hematoma is not a stroke. I said that yesterday, I'm gonna say it again. Not a stroke. But anyway, you will see all these. The two things I see most often in terms of intracerebral hemorrhage are the ICH or the IPH. Well, IVH as well with interventricular, okay? So all of these are, again, approximately 20% of strokes, give or take about 5%. In the ICH population. And we talked a little bit about this yesterday. Non-structural hemorrhages are things that don't have to do with like AVMs, the structural vascular supply. And then the structural hemorrhages are things like aneurysms and AVMs. Again, we talked about this yesterday. The incidence varies by race and mechanism as well. When we look at risk factors for ICH, obviously number one is hypertension. Older age. Are they on anticoagulants? Because that does increase, even though it's a small risk, it does increase their risk. Amyloid angiopathy are abnormal protein deposits that are put, that affect the vessels and make them frail. That's when you do MRIs on these elderly people and you just see microbleeds everywhere. That's amyloid. And that can sort of precipitate a larger bleed. Dementia, interestingly enough, because dementia is a vascular disease in many patients. Renal or hepatic failure, certainly hepatic failure because of coagulopathies that happen. Smoking and excessive alcohol use, interestingly enough. Okay, well, going back to the Greater Cincinnati Northern Kentucky Stroke Study. First incidence of ICH, and you can see sort of in that particular survey, the sort of the bars here with older age and also differentiating by race in that particular area's population, which is pretty rural. Okay, mortality can be upwards of 30 to 50% at 6 months. It can be 50% at 1 year. Up to a quarter of ICH patients can be independent at 6 months, while 60% of them of ischemic stroke patients are independent at 6 months. So you have quite a decrease in the independence for these ICH patients versus ischemic stroke patients. This might look familiar to you in terms of predictors of outcome. Here's what I would say. Is there an ICH? I'm not on my, nope, okay. Here's what I would say about these predictors. These are components of the ICH score, okay? As providers, I have to put an ICH score, otherwise my stroke coordinator calls me and says I need an ICH score. So predictors of more severity in the illness is hematoma volume. The volume matters. You know, we said yesterday that a volume of greater than 30 mils was associated with poorer outcomes, and that's true. The Glasgow Coma Scale is in here because number one, we all use it. It's universal. And for patients who are less responsive, it does give you an option to assess their responsiveness. Interventricular hemorrhage. This is obviously a thalamic hemorrhage and obviously extension into the ventricle as well. Age. ICH location, yes.
How do you determine the origination point? Just based off of like what you know about the vessels, or so?
Yeah, and the other thing too is that anytime basal ganglia hemorrhages typically happen out here, they typically don't get into the ventricle, and so they can, but thalamic hemorrhage, because it is, and you know, as I sit here and I look at this. I have to wonder, because I'm seeing a lot of swirling. I wonder if this is a hemorrhagic transformation of an ischemic stroke, because I've got edema right around here. Anyway, this is not my scanner. I would know more about it, but because the thalamus forms the walls of the third ventricle, when I have a thalamic bleed, it's very easy to get in the ventricle that way. And so most of our interventricular hemorrhages, not all of them, but a lot of them, if it's supratentorial, is related to a thalamic bleed. But if you get a big volume, of course, you know, it gets the basal ganglia too. Yeah. But interventricular hemorrhage is associated with a poorer outcome too. Those patients are hard to wake up. I don't care what you do with them. I mean, the hemorrhage can go away. Those patients are hard to wake up. The location matters, whether it's supratentorial, meaning the brain is covered in a covering called the meninges, you all know that, but it comes back and it folds back in on itself between the cerebrum and the cerebellum. The cerebellum doesn't have a whole lot of room. So the ICH score gives me a score for infratentorial, meaning cerebellar, because I don't have a lot of room there. So if I have a big bleed there, their outcomes are going to be poorer. And then cerebral edema causing midline shift and potential herniation.
So can you go back just so the supratentorial is
Supratentorial is frontal, parietal, temporal, occipital. So it's everything above the cerebellum.
Above the cerebellum.
And infratentorial is basically cerebellum.
So when they talk about like the transentorial notch, they're talking about crossing from supratentorial to infratentorial?
No, typically when they're talking about that, like transtentorial herniation, yes, it's talking about that, but you'll have compression on the midbrain as well, but it's talking about that tentorium there.
Okay.
Yeah. Okay. Yeah, so all of these are components of the only part that's not a component is the cerebral edema. Let's see what's here. Okay. This is a non-con head CT in here in A, and you can see there's a hemorrhage here. And then this is the CTA. And you can see in C there's this arrows that are pointing. That is a spot sign right there. That patient has active extravasation of contrast. So hemorrhages should get a CTA because you can actually see that. Now you know that this patient, that hemorrhage is probably not going to stay there. That hemorrhage is probably going to expand because you've got active bleeding. So if you have a patient like that, and then you know, is my anticoagulation, what is that status? Have I corrected as much as I can correct? And is my blood pressure under control? So the CTA spot sign is an indication to you that you have a high risk for expansion of that hemorrhage, and you've got to get stuff under control as best you can. So that is the CTA. So we talked about a hyperdense MCA. We talked about the dot, the M2 dot. Now we're talking about a CTA spot sign in ICH patients. Okay. This is the ICH score. Now this is what I want. I know that this slide says predictors of outcome. I see that. I hear that. This is the ICH score, so you may want to mark that. Is that in your book at all? Okay. This is Claude Hempel's work and his group's work. And what he says about this, he's really disturbed about the fact that we use this as predictors. And if you get on MedCalc, I don't know how many of you use MedCalc to do your scores and that kind of stuff. But if you get on MedCalc, he has a nice little interview in there. And he talks about how he's really disturbed by how people have said, you know, I had a patient with an ICH score of 4, and I just told him, well, there's nothing we can do for them because they have a 96.7% 30-day mortality, and there's just nothing we can do for them as a predictor. He was very upset about that. What he intended to use as the ICH score is as a communication tool to the severity of their illness, not a predictor of outcome. A lot of the mortality that we have in these patients and with ICH scores 4 and 5, a lot of the mortality resulted from withdrawal of life-sustaining treatments. The families just said, you know, they wouldn't want to live with that kind of severe disability. And he intended this particular score to be used not any different than the NIH score. We don't use an NIH score to say, hey, they're going to die if they have an probably are, but I mean, you know, as a predictor of outcome, we use it as a communication tool to really relay the severity of the stroke. And that's how he wanted this to be used. The problem is now we're using it as an outcome because they had a mortality measure associated with it. So I just want you to be careful in the interpretation of your ICH scores. It's meant as a communication tool, not as a predictor. And again, a lot of the patients, they had withdrawal of life-sustaining treatment, and that influenced the mortality. which is always the problem when we use mortality as an outcome measure, okay? The FUNC score, we don't use too much anymore, but what I will say is it dichotomizes some of these things a little bit better. And also it gives a score for premorbid cognitive dysfunction. So it gives you some of that, and again, higher scores are associated with more functionality. Okay. Hematoma expansion is front-loaded. That's why that first, half hour, that first hour is really important. These are, and this continues to be shown over and over and over again. I mean, Tom Bright did some work in the late 90s, Davis did some other work, and this continues to be reiterated over and over again. It's front-loaded. 72% will have some hematoma expansion in the first 24 hours. A little over a third of them will have significant expansion, okay? And about a quarter of them, the enlargements in the first hour. So that's the reason why we repeat head CTs, right? They come in the ER and we get a head CT, we get a CTA, and about 4 hours later we'll get another one, or unless they sort of decompensate. But that is why we do that. Okay. We don't really know, but here's what we think we know. We think that the primary hypertensive, this is a basal ganglion hemorrhage, pretty classic. Left basal ganglion hemorrhage right there. Pretty classic. We think it's caused by a rupture in those really, really small vessels and the small arterioles, and those penetrating arteries that we looked at yesterday. We looked at a lot of those little branches like the thalamo-geniculate perforators or the lenticulostriate perforators of the MCA. We think that's what causes them. Typically, these primary hypertensive hemorrhages typically have a more severe presentation, and again, they're at high risk for hematoma expansion. Okay, so here's some common etiologies there. You'll see the left on the thalamus. See how this goes, the difference between this one and that one. Now you may get a little bit in the posterior horns, but you're gonna get a lot with this thalamic hemorrhage right there, because it's, sorry, I'll get out of the way.
Oh, you're fine.
The cerebellum, there's not a lot of room in the cerebellum. Neurosurgeons, and we'll talk a little bit about the surgeries in just a moment, but the neurosurgeons are more likely to decompress the cerebellar, either infarct or hemorrhage, once they look at the vasculature in that hemorrhage, than they are any of these others. And then that pontine hemorrhage, that's a palliative situation. You're not gonna get over that. Okay. So the location does matter. Okay, amyloid, angiopathy. If I have an older person and they have a hemorrhage out toward the cortex, I'm looking for a brain tumor or amyloid or an AVM or something like that out toward the surface of the brain. Those are not typically hypertensive. It's cold in here. Are y'all cold?
Yeah.
I mean,
There's that temperature.
yeah.
See if it'll work.
I'm watching everybody like,
I
put
think
on their jackets, and I'm like, you know what, I'm cold too.
It was warmer in here.
It was warmer in here, yeah. Listen, when I see the guys putting on jackets, I know that it's cold.
True story.
When I see y'all putting on jackets, I'm like, maybe it's a little cold in here. Okay, again, it's associated with dementia.
Oh,
Elderly patients, definitely more at risk here, and then microbleeds on that GRE that we saw yesterday, okay? But anytime I see an elderly patient, they have surface hemorrhages like that, I'm like, not hypertensive. Not hypertensive, but you gotta rule out the brain tumor as well in these patients, because you can actually hemorrhage into a brain tumor. Okay, don't worry about this thing don't worry about this graph here. I'm gonna explain that here in just a minute. Anticoagulation, obviously, probably, when I looked at Eliquis, apixaban, like their hemorrhage rates or the rate, it's like 2% or something like that. I mean, it's really low for them. The problem is when you get the hypertensive patient on a blood thinner with all these other risk factors, and that just increases their risk. Patients who are on no blood thinners, in this very small series, patients who are on no blood thinners, typically the hematoma expansion is front-loaded within the first 24 hours. Okay, that's all I want you to get out of that. Obviously, if they're on blood thinners, that risk of hematoma expansion sort of expands out. But the only thing I want you to get out of that is it's front-loaded. Oh, hang on a minute. Other etiologies. You know, we talked about not brain tumors, but trauma yesterday. This is a GRE sequence here. You can see the blood. These are frontal contusions in this particular patient. This in the middle is a hemorrhagic transformation of an acute ischemic stroke, and I know it's a stroke, a ischemic stroke first because I have all the hypodensity here in this MCA territory. You're not going to see that in a primary hemorrhage. You'll see it. So this patient has had a hemorrhagic transformation of their ischemic stroke. Okay, and this is a brain tumor. It's nice and round. Okay. Yeah, so I have all that hypodensity there, so I know that middle one is a hemorrhagic transformation.
When we're looking at these MRIs and stuff like that, the brain tumors tend to be more heterogeneous than homogeneous, correct?
Yes.
Okay.
Yeah, and they tend to light up with contrast.
Right.
Which is one of the reasons why you would get a contrast. So
Right.
if I came in with a patient with stroke symptoms and the CT is kind of like, because you can have patients with meningiomas
Correct.
on CT, and they don't really, and they don't really light up very well. And so when you do the contrasted MRI, it'll light up that way.
Yeah, like a glioblastoma is just heterogeneous, just crazy.
You're gonna see a glio on CT.
Oh,
probably
absolutely.
Because of all the edema. Yeah,
But-
this right here is probably a Met.
But when we're talking about like the densities and stuff like that, the
Mhm.
bleeds tend to be more homogeneous than we see this in the reports. So,
Yeah, exactly.
so,
Yeah, and I think it's helpful to pull them up and then look at the reports and see what the verbiage the radiologist is using, and that kind of thing. But that neoplasm is probably metastasis. It's nice and round, with some edema around it as well.
right.
Okay. All right, how do we manage these patients? Obviously, the main thing is supportive care for sure initially. Do they need to be intubated? Keeping their temperature at a normal level. Sometimes when you get blood in the ventricle, I'll just tell you, because in surgery that was my whole job when we were doing like spinal cord and that kind of stuff, and we'd open up the dura. My job was to keep blood out of spinal fluid. Blood in the spinal fluid creates a lot of inflammation, and you have these people who have these fevers and you can't bring them down, and it's not infectious and all that kind of stuff. So people who have blood in the CSF, like they have interventricular blood, they're sometimes they have tough fevers to treat. Obviously, blood pressure management, reversing the anticoagulation, and monitoring all these things. We talked a little bit about ICP yesterday, and if you have a way to measure that, and if you have to put in an EVD, you will. Seizure prophylaxis is not recommended in the guidelines, or at least there's no data to suggest we should put it on everybody. We used to I had a hospitalist or I had an intensivist who would put it on everybody, and we quit that. You should only do it if they are actually having seizures. Do y'all automatically start Keppra?
Only if we see seizures.
Yeah. The indication for me to start Keppra is if I have a cortical, like something on the surface by the cortex, or something, because that's a little bit more eloquent, but I won't keep them on it.
We put everyone on like precautions if they come in with the brain.
Yeah.
Like, pads on the bed, and then it's like in everyone's brain to look for it. But
Yeah. And cause like up on the I guess med surg unit for neuro, people are either actual or potential.
Yeah,
So
exactly.
potential, you just make sure you have your
You're just doing all
suction,
your
your
stuff.
whatever,
Yeah.
but we don't have the padded, we don't
Yeah.
generally pad the rails unless they're actual, or
Yeah.
like they have a history of seizures, and then we'll So we're not
otherwise,
prophylaxing
everybody.
Otherwise every bed would have.
Everybody would be on Keppra.
Yeah, so,
Yeah,
and
exactly.
have bed rails
You know,
and
and
stuff.
Kepra's not benign either. I mean, it makes these older people, makes them sleepy and makes them tired. Exactly. All right, here's the problem with blood pressure. Does blood pressure elevation cause hemorrhagic expansion? Or does hemorrhagic expansion with mass effect cause blood pressure elevation? We don't know. We don't have a clue. We know that they're associated, but we really don't know. And so this is an older study that looks at systolic blood pressure in particular with percent of hematoma enlargement. So we don't really know the answer to this question. Okay, now we're gonna get into trials, and I'm gonna try to make it like what you need to sort of be aware of. These are the attached trials, and there's attached 1 and 2, and this is Adnan Qureshi's group, and they really looked at how do we treat hypertension and cerebral hemorrhage. How do we treat that? And so what they did was they had 3 groups, and they really determined that probably that a blood pressure reduction to less than 140 is probably safe, okay? Is what the guideline says. And so they looked at, so initially, in this initial trial, they just looked at these 2 groups. There's a small effect on hematoma expansion, which further sort of complicates our, did you get that, or do you need me to go back? You got it? Okay. Yeah. And then we get into the INTERACT trials with Craig Anderson's group. And so, so again, the target group is a systolic blood pressure of less than 140, because before these trials came out, the target blood pressure was less than 180 in these hemorrhages. That's shocking to some people, but it was. Again, the relative risk of hematoma growth was 30% lower in the target group. Aggressive lowering of the blood pressure was not associated with adverse events at 30 days. And so then we get into INTERACT 2, another of Craig Anderson's group. And they looked at rapid lowering to less than 140 versus lowering less than 180. And the agent used is different, so they could have used anything. He does a lot of his work in Asia, and in India and places like that. And so they don't always have the drips. They have bolus drugs, and they have drugs that we don't even use here. So it didn't matter what drug they used on the INTERACT trials. And so the primary outcome was death or serious disability at 3 months, and look at the modified rank at 3 to 6. Okay. There was no difference in hematoma volume between the groups. And really, it trended towards significance in terms of the primary outcome, but not a whole lot. So the INTERACT 2 trial showed that, you know what, we really didn't have a whole lot of adverse events from moving it to 140. So guess what the guidelines did? The guidelines said it's probably safe. But here's the thing that you need to know. 66% of the subjects in the intensive group failed to achieve or maintain their targeted blood pressure. So when you look at this trial in that context, I don't think you can say anything about this trial. The guidelines do, but I don't think you can say anything about this trial. Anne has some definite opinions.
So they didn't
They didn't maintain the blood pressure.
they didn't achieve the goal, but they still published that as like a
Oh,
trial.
it's in the guideline. Look at the guideline. If you look at the guideline, it'll say reduction, and the hemorrhage guideline, it'll say reduction to blood pressure to less than 140 over 90 is probably safe. And then they have all this fine print that attached to the trial.
And that's like kind of the standard for us, is if it's an ICH, it's less than 140. Like,
Yeah.
unless they specify something
Yeah.
different, like you're just gonna expect.
You're just gonna go to 140.
You're
Exactly, but it's because of these trials.
But then
Because
they
before
usually
it was-
liberalize it.
Yeah, then they,
Yeah.
they'll
that's because of
liberalize
these
it
trials.
after a couple days or
Yeah,
so.
and we liberalize it, exactly. We get that tight control. Now, Adnan Qureshi's group said, you know what, we're gonna trial the same thing, but we're gonna use Cardine. We're gonna use one drug, we're all gonna use the same drug, to make sure that we get to target. because we don't know anything if we don't get to target. Only 12% of his patients in the aggressive management arm failed to achieve the therapeutic target, and it was stopped early for futility. They were like, we're not having any difference in the 90-day outcome on death or disability. And that's why I think death and disability is like a horrible endpoint, because there's so many other things we want to know about other than do people die. Obviously 25.6% of those aggressive managed patients had serious adverse events, however they describe those. Okay, so now we have Interact 3, okay? Interact 3 looks at a bundle. And this is Craig Anderson's group. A lot of them, you can look at the countries, they're low and middle income countries. So it's Brazil, China, Asia, and interestingly enough, Chile. He's got investigators everywhere. So they did a bundle. And they said, what if we lower their blood pressure? What if we control their glucose? Because we think that's a good idea. What if we really treat their fever? And what if we do some rapid INR reversal of less than 1.5? You know, none of these countries probably have, maybe Chile does. They're probably still using warfarin. If they do anything, they're probably not using apixaban and all that kind of stuff. So what if we did all that, and then what would happen? So we had hundreds of hospitals across the globe, 7,000 patients. Several were lost to follow up. Okay. So one more slide here. Okay. There was an 8% absolute difference in the hypertensive treatment following the care bundle. 24, and you can see on the one hour mean blood pressure, you know, kind of, is that significant difference? I don't know. Does it mean anything clinically? We don't know. The blood pressure achieved, was finally achieved in 2 hours in the target group. There's no difference in temperature control or INR reversal between the groups. They're still going to do that. Minimal difference in the glucose. The care bundle achieved a protective odds ratio of 0.86, so it was like 14% more compared to usual care, but there was no significant difference in the odds of death at 90 days or even at 7 days. And there's no difference in the place of residence at 6 months. So, you know, when this trial came out, I was like going, okay, and now what? And yeah, and so, you know, so you have some statistical significance. The question for us as clinicians is it clinically significant? I mean, anything can be statistically significant, but is it clinically significant? So you have 6.3 millimeters of mercury difference in blood pressure at 1 hour average, 2.9 millimeters. Is that, no, it's not significant. Few patients receive the whole care bundle. So you kind of shot yourself in the foot if a few of them receive it. The 90% Chinese enrollment sort of challenges the generalizability. And then the data on hemorrhage enlargement is a little skewed, okay? So Interact 3 was a very interesting thing. Here's the take-home message for all of this stuff, is that all of these trials are looking at blood pressure lowering, and maybe it's sort of a bundle to figure out what we can do to improve outcomes from ICH. And what we have determined, and what you'll hear more about tomorrow if you go to the conference, is going to be, we need to do more than, we need to do more bundling, and it may not be just one sort of factor, okay? Maybe more than that. More work to do. So the goal, so looking at anticoagulation, normalize the INR to 1.4. Any patient on warfarin, you guys give Kcentra, 4-factor PCC. When they're on warfarin, we do too. And you should have some time frames in terms of getting it. Any ICH in a patient on warfarin with an INR, or any patient with an INR greater than 1.5 is life-threatening, okay? Now, how do you do that? FFP is one. A lot of our patients can't handle the volume, and you know what? I don't have time for it. I mean, I'm just gonna be honest with you. If I have somebody come in super therapeutic with a hemorrhage, I don't have time for the lab to throw out FFP. And so we'll go straight to the, 4-factor PCC. With a vitamin K, you have to use the vitamin K with it, so don't forget the vitamin K with a 4-factor, okay? 4-factor PCC is a concentration of vitamin K dependent coac factors 2, 7, 9, and 10. It should be available in centers, but I can tell you it's a smaller volume, it's like, I don't know, like 30 cc's, and I can get a faster INR correction. I can correct them in 20 minutes on the way to the OR if I need to. So it's fast, 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 and I don't have to worry about dripping in FFP. Very slow process. Dabigatran, I probably would know that the specific reversal fact. I feel like you guys already do. Praxbind is for dabigatran, and then you have rivaroxaban and apixaban. The true reversal agent that shows hemostatic efficacy is andexanet. We talked a little bit about that yesterday. Depending on the dose that they're on, depending on when the last time that they took their particular drug, will give you the dosing, whether it's a low dose or a high dose. And there are antidotes that are specific to each oral anticoagulant. And really the use of 4-factor PCC, it is off-label. And it won't reverse it, it just dumps factors into your blood, okay? All right. I'm gonna go through this just a little bit. The Anexa eye trial, one of the things that when people talk about outcomes and that kind of stuff, it was not an ICH treatment trial. It was really looking at hemostatic efficacy and whether there was a reduction in factor 10A activity in these drugs, okay? I'm looking through all of this. There was no significant difference in thrombotic events between the groups. Why is this ICP algorithm in here? Okay, so again, thrombotic events, 10.3% andexanet versus 5.6% in the usual care, and that was significant. That should say there was significant. That should not say there was no significant, okay? There was significant. It's 0.4048. And that's what prompted the FDA not to give the indication, because they were concerned about thrombotic events. But again, like I said yesterday, I looked at 4-factor PCC versus FFP. I looked at Praxbind. I looked at those studies, and the thrombotic risk was about the same. So I'm not sure why the FDA decided that this was a worse thrombotic risk than giving Praxbind or giving 4-factor PCC for warfarin. Not exactly sure. Okay. Now, I did not know why this is here, and I meant to move this. This ICP treatment algorithm, I'm gonna let you guys, if you wanna take a picture of that, you can. This is available. This is if you have an ICP problem, what do you do, okay? And if you have an EVD, and you are transducing that, what do you do? So I'm gonna let you have a go at this. The main thing is that your cerebral perfusion pressure should be greater than 60, okay? Y'all got it? Okay. Okay. Again, randomly inserted. When you're trying to manage ICH, particularly those with a ventriculostomy, you're going to have ICP and being able to mitigate any challenges you have with managing that. Keeping the head in bed raised, and I'm going to tell you, keep the head at midline. It makes me nuts when I walk in there and I see the patient. I typically walk in and we have like a little cart with like towels and stuff when I walk into the ICU. I typically grab one or two because I know I'm gonna have to prop somebody's head up when I walk in the room.
And it goes the other side.
Huh?
And then it goes on the other side.
Exactly, I know, yeah, listen, that's why I've got two. Anyway, again, sedation, if you have to do a blockade, I rarely have to do that for management of ICP for stroke. Trauma patients, a whole different ballgame, especially my young ones, a whole different ballgame. But the real gold standard is a ventricular drain in these patients. You can use some osmotic therapy, hypertonic saline. I'll give 23.4 in a crisis. Mannitol, you have to be careful with kidneys with mannitol. You can push mannitol, you can drip it in, but again, the 23.4 works for us. Do y'all give 23.4 in your IC?
Yeah, sometimes.
Yeah, we do it occasionally. Do you use 3% drips?
Yeah, that's more common.
Yeah.
I've seen the 23.4 like a few times.
Yeah, urgent.
Like
when it's
really,
urgent.
yeah, really.
Yeah,
like that.
yeah. Yeah, one of the things too is that, one of the things early on when we were using that is, we had a policy that said you needed a central line or a PICC line to get that 23.4. And, the Neurocritical Care Society came out and they did a study on, not using it routinely, but if you needed it, don't wait, if you're in a crisis, that it's safe to use with a good peripheral.
Mm-hmm.
And I've had to do that a time or two. I was like, I can't wait on the PICC team to come in here and give me a PICC line. I mean, this patient is gonna herniate and die if I don't do something, so. Anyway, avoiding those, and that should say hypoosmolar fluids. So avoiding those hypotonic fluids is important too, and maintaining euvolemia, getting those I's and O's right. Hyperventilation is only a temporary measure, but if you have somebody with a PaCO2 and they have a lot of edema and you've got a lot of increased ICP, and they have a PaCO2 of 45, you can move that to 40, that's okay. I mean, you know, using the ventilator and using your CO2 as a measure, sort of as a chemical, vasoactive, situation, so you can get control of the ICP. But in stroke patients, I don't typically have, issues with ICP, typically it's in the trauma patients. Although you can, but it's not very, usually they're a little bit more easier managed. Primary interventricular hemorrhage. When we have a primary interventricular hemorrhage, they just have hemorrhage in the ventricle. They get a CTA 100% of the time in my shop, and the reason why is because, and they might get an angiogram, and the reason why is they could be hiding an AVM or an aneurysm. And if you're just treating the primary interventricular hemorrhage, it's pretty rare to have that, but you get a lot of yield out of angiography. Okay. It could be strictly hypertensive, but again, you want to rule out that AVM or aneurysm, or something that you need to intervene on, right? Up to 40% don't survive the hospitalization. Those patients are really challenging. If they do survive, a lot of them have chronic hydrocephalus because they're, the villi that are supposed to resorb CSF are all messed up because of the blood. So they're all, you know, they're all clogged up, so they don't absorb CSF in the way that they should. And so those patients, typically, if they survive, would need a shunt at some point. Y'all use interventricular TPA for patients with IVH?
We have, I think, right? The TPA
Yeah,
and
it's
the
a-
drain?
Yeah, sometimes the like the APPs will come
They'll
in
come up and do it.
and still,
yeah.
yeah.
Yeah, is it to clear the blood, or is it to clear the tube? Catheter?
Yes.
To both
So
or
to,
both?
to both.
To both, yeah.
I think is it to both?
I've seen it.
Yeah,
I wanna say they've done it both.
Well, I know that the duct does the,
Yeah, they'll do
TPA.
installations and
The-
they'll also do the drain clears.
Yeah,
after,
okay.
after the MMA,
Mhm.
uh,
Oh, yeah,
embolization,
yeah.
and then once the bleed source is stopped, then they'll go and put in like Tancade
Gotcha.
to loosen that up so that it drains.
Yeah, so that it drains better, yeah. Yeah, so the CLEAR trial, when we look at interventricular injection of TPA, that's a sort of a milligram TPA Q8. That's sort of a CLEAR trial, protocol that they use. I don't use a whole lot of that. I mean, I'll do it to clear the catheter. You do get clearance from the clot. I just don't know if the outcomes are any different if you get the clot cleared versus not getting the clot. You do have reduction of the clot for sure, yeah. And those CT scans are a killer. The night shift hates us. Those 5 a.m. We talked about seizures a little bit. they're more frequent in hemorrhagic stroke than ischemic stroke, especially the lobar, the ones that are closest to the surface, are ones that are more at risk because it's near the cortex. When you have a patient who doesn't seem to be waking up, I have a very low threshold for throwing an EEG on somebody, because they could have non-convulsive seizures, so they could be, that could be a reason for their decreased mental status. Again, we talked about this, routine prophylaxis is not necessary and not in guideline, but again, EEG monitoring, I'll throw an EEG monitor on these patients. Okay, all right, let's talk about surgical stuff here for just a minute. We're good. The management of ICH, so surgeons always want to do surgery. And they're always looking for a reason to do surgery. And when they look at trying to remove clots and hemorrhages, and we'll see some of the minimally invasive stuff in just a minute, there's a subgroup of patients that do better. The deeper hemorrhages, we're gonna look at a couple of trials, but the bottom line is the deeper hemorrhages seem to do not as well. There's a subgroup that benefits in surgical removal of the hematoma, and that's in patients that have sort of a cortical, more toward the surface of the brain. And so that's a patient population that actually does benefit from surgical evacuation of that hematoma. Okay. Again, more of, I'm gonna skip over this because again, they're excluding people, okay? Now we get into the minimally invasive stuff like the MISTI trials. And you can see when they do minimally invasive stuff, they work through a tube. Do y'all do minimally invasive evacuation of clots? Yeah, like brain path and that kind of stuff. You do any of that?
I mean, I know that we do like hematoma evacuations and that sort of thing. I just don't know if I ever thought of brain surgery as minimally invasive.
Oh, yeah.
I was happy you said it.
Yeah.
Because I thought
It's
Yeah.
not brain surgery.
It's not, yeah.
It's just brain
Yeah.
surgery.
It's just brain surgery.
Just brain surgery. So they work through a tube that's inserted, and they sort of dissect through the layers, but they work through a tube. And then because they're working through that tube and they access that clot, they can just work right there. And so, but it's real
Just
simple
right there in the
aspiration.
ring.
I know, it's a little crazy. So it's real simple aspiration,
Just a couple
but they
burns.
have, they have a little rotator that breaks up the hematoma, and then they suck it out. And so they can also lavage the cavity as well. They can put in some medication in there to treat that oozing vessels, which is, what we do, we use thrombin in our brain surgeries and we put it on a little bit of a mesh when we do brain tumor resection, so it's similar to that. But you can see the pre and the post in terms of hematoma evacuation. Now, and Apollo and brain path are two of the ones that are most used. The question is, are the outcomes any different? And so you get into the MISTI trials, we get a MISTI 3, MISTI 2, and those are stereotactic guided clot aspiration. Y'all know what stereotactic? Y'all do stereotactic brain surgery here?
Do we? I mean, obviously.
I think you probably do.
No idea.
Okay, so stereotactic brain surgery is really kind of interesting. You take the patient down and you do these really thin slice CTs, and it's less than a millimeter, maybe a half a millimeter. And we do stereotactic radiosurgery for brain tumors all the time. Because what you want to do is, once you map that out, you take them down to, we do MRI actually with that. So you take them down to MRI, but you do the same technique with CT. And then